Hello, this is Farah Douglas, President and CEO of the Liver Health Foundation. Thank you for joining us. Liver Health Foundation is a California-based entity. Many of the members of our board of directors represent liver patients and caregivers. Liver Health Foundation's Medical Advisory Council, led by Dr. Sami Saab from UCLA, has 30 members who are some of the best hepatologists and liver surgeons in the United States. Our mission is to provide updated and accurate information on liver health, promote prevention of liver disease, advocate for equity in access to healthcare, and host community and physician-centered educational programs. To see the complete list of our programs, please visit our website at liverhealthfoundations.org. Tonight's program has been made possible by a grant from Albireo Pharma. We thank Albireo for their support of our efforts and hope you find the information helpful. Tonight's subject is PFIC, a rare pediatric liver disease that, if left untreated, can cause other liver diseases. We hope to continue bringing you information about the rare liver diseases in children and adults. Our goal is to provide updated and accurate information to liver patients and their families, and provide an opportunity for them to ask questions from our expert presenters. It is now my pleasure to introduce Dr. Renee Romero, who has generously accepted to be the presenter for tonight's program. Dr. Romero is Professor of Pediatrics in the Division of Pediatric Gastroenterology, Hepatology, and Nutrition at Emory University School of Medicine and Children's Healthcare of Atlanta, where he also served as the Medical Director, Pediatric Liver Transplant Program, and Clinical Director, Pediatric Hepatology from 1999 to 2022. Dr. Romero has been the System Director for Transplantation at Children's Healthcare of Atlanta since 2017. His academic work has focused on the clinical management and outcomes of pediatric liver disease patients and pediatric liver transplant recipients. He has been the site principal investigator in several NIH multi-center clinical consortiums, such as the Childhood Liver Disease Research and Education Network and the Pediatric Acute Liver Failure Study Group. Dr. Romero has also been involved in industry and sponsored trials for hepatitis C and PFIC therapy in children. He has served on the United Network of Organ Sharing, known as UNOS, Pediatric and Member and Professional Standards Committees, and the UNOS OPTN Board of Directors. Having had a long-term interest in medical education, he has previously served as the program director for the Emory Pediatric Gastroenterology Fellowship Program for nearly 10 years and established the Pediatric Transplant Hepatology Fellowship Program, one of the first research program by accredited by ACGME in 2007. Dr. Romero and his wife, Elena, have been married for 39 years. They have 3 children and delight in their 2 grandsons, ages 1 and 4. Dr. Romero is a huge fan of Atlanta United and the Atlanta Braves. Cycling on long rides, beach vacations, and dancing to Latin music with his wife are the best relaxation methods for Dr. Romero. Dr. Romero, thank you again for your support and participation. Would you please start the program?
Thank you very much, Ms. Douglas, and I appreciate greatly your invitation to speak tonight, and appreciate greatly also the support of Albireo for sponsoring these programs, which are so important for so many families. And I'll go ahead and share my screen and get slideshow going. There we go. So tonight we're going to be talking about progressive familial intrahepatic cholestasis, or PFIC, but I hope to really provide an alternative title, which is presenting you families insight and concepts regarding this illness. I have just a few disclosures, which have no real, for Alberio as a consultant, Miriam also, and research grants for Gilead, but I'll be speaking only about disease background and FDA-approved therapies for this talk. The goals of this talk are to develop an understanding about the structure and function of the liver as it relates to PFIC diseases, to understand how the alteration of some normal liver processes in PFIC relate to those symptoms and to outcomes, and to have an understanding of the available therapies for PFIC and how those impact symptoms or progression of liver disease. So we'll start off with some background, which will hopefully then lead into the understanding of our potential treatments and how the disruption of normal functions impact the progression of liver disease. So the liver is the largest organ in the body, and it serves multiple functions. One of the main ones is the production of a fluid called bile, which we'll talk about a little bit later. It also makes an abundance of proteins for the body, and it regulates those proteins. It importantly makes factors that play a role in the blood clotting, and it serves as a filter for the blood in the body and eliminating toxins through the GI tract. It also plays a role in immune regulation and prevention of infections, and in addition to many other regulatory events, has an important role in the management of glucose. In fact, there are so many functions of the liver. One of the famous hepatologists, one of the most famous hepatologists in the world, said that the number of functions of the liver are only exceeded by the number of tests tried to design to test those functions. So it's quite a number. One of the important things to understand about the liver physiology is its blood flow and its role in being the first organ to see the outside world besides the skin. So when substances are absorbed through the intestine, they immediately go through the portal venous system, which supplies 80% of the blood flow to the liver. Here it filters through the liver and then back to the systemic circulation through the hepatic veins and back to the heart. So the substances, importantly, substances absorbed from the intestinal tract will always, or almost always, be seen first by the liver. I'm going to take you now into a microscopic journey into the liver. And this is a biopsy, a normal biopsy of a normal liver, okay? The liver has various regions. We think of it in 3 distinct parts. The entryway at the microscopic level is this area here called the portal triad. It's called the portal triad because it contains 3 structures. The portal vein, which is the smallest branch of that big vein that I showed you on the previous slide, a small artery, and then a tubular structure that carries the fluid that the liver produces out of the liver and to the intestinal tract called the bile ducts. The liver cells are these pink structures aligned in what we call cords, and the white spaces between them are actually the small capillaries or blood vessels that carries the blood that's filtered through the portal vein, through these structures here, and to drain out the central vein. And let me get, so looking at it in a little bit more of a cartoon structure, oftentimes we think of the lobule of the liver, or the smallest functional branch of the liver, occurring in a hexagonal kind of arrangement around a portal vein. And these orange structures are the equivalent of the pink cords going through here. If we look at the actual vascular space, the little white areas here in this cartoon, you'll see that the blood flows through these little capillaries, but these capillaries are very specialized. They're not completely contiguous. They're not intact. There's little gaps in them called fenestrae, which is Latin for windows. And that allows substances to go between the single layer of cells in just adjacent to these pink cords, so that they can be readily taken up by the liver cells or hepatocytes. This allows for a lot of exchange of material and processing by the hepatocytes. If we look at it in a more physiologic way, we have these structures down here in the lower part of the slide. And we see that the portal vein is bringing in the blood. These are the lining cells of the capillary, and then that space between the liver cells. And so you can see that the liver cells sit in a kind of mid position between the blood vessels and then the space that is producing the bile. And that runs in a counter current in an opposite direction to the blood flow. So you can see that there's a ready exchange of materials taken up by the liver cell, processed, potentially put into the bile, or potentially processed and put out back into the circulation. And this is a theme we're going to see over and over again, and plays an important role in bile and in liver diseases such as PFIC. So I've said this word several times now. So what is bile? Well, bile is this green-yellow fluid that's produced by the liver. This is actually a stream of bile coming out of the opening in the small intestine. This fluid is a very complex mixture of water, electrolytes like sodium, chloride, bicarbonate, certain fats, and a very special chemical called a bile acid that is produced only by the liver. Bile also contains some waste products, mainly bilirubin, which is actually the substance that gives this greenish color to the bile and is what produces jaundice, the yellow in the eyes or in the skin, when it's not eliminated in the bile. So bile is produced in the liver, the vast majority of it being produced at the moment we're eating a fatty meal. Only a little bit gets stored in the gallbladder, and then most of it comes out through the bile ducts and joins fluids from the pancreas into the small intestine, where it helps digest fats primarily in the feeding. Now, what allows that to happen is, fats, and what we have is mainly like water along the lining of the intestine. As we all know, water and fat do not mix very well, and they stay separate. But bile salts are a chemical that's produced by the liver that acts as a detergent. And what do detergents do? Well, the detergents have an area of the molecule that that does not like water, and an area that likes water. So it forms like a circle around an oil droplet, and this is called a micelle. So bile acids form micelles for fat that allow us to then absorb that fat and process it appropriately. As I mentioned also, bile itself provides the fluid medium by which substances that are processed by the liver and toxins that need to get out of the body get put into the GI tract and then excreted in stools. So this is a complicated slide, but we're going to just focus on some aspects because of the theme that it involves. So the driving force when we're eating and our signals from our body are saying produce bile. That flow and production of bile is mainly determined by the secretion of bile acids being put into that space between two liver cells called the bile canaliculus. And this is the rate limiting step for the production of bile. And as you can see by this cartoon, there are many processes and transporters involved in that process. So bile acids are these chemicals produced by the liver that actually have a backbone made of cholesterol. Through a number of enzymatic processes, it produces two main bile acids that then get attached to another molecule, which is transported to a specific transporter at one edge of the liver cell, and then actively put into the space between the two liver cells, which is called the bile canaliculus. And this is the smallest branch of the plumbing system of the liver, if you will. In that, other transporters are putting in other materials that are constituents of bile. These two very tightly opposed liver cells form a barrier, and these molecules here make a driving force for as osmotic particles, meaning their presence makes water want to go into this space. And when we're actively secreting bile acids into this space, bile flow happens because of the force of the liquid going into that space. Later, as the bile travels through the intestinal tract to the last part of the small intestine, the bile acids are again recognized by a transporter, basically hitching a ride back into the portal venous system and back to the liver. So the body is actually quite a tremendous, excellent recycler of bile acids. So we make about 2.2 to 6.6 grams per day of bile acids from the liver, and it's excreted into the small intestine when we eat. And once it gets to the very last part of the small intestine called the terminal ileum, which is just before the beginning of the right side of the colon or large intestine and near the appendix, that's where that concentration of receptors that bind bile acids to be reabsorbed are located. That gets put back into the portal venous system, flows back to the liver. Only a very small amount of bile acids are actually lost in the stool under normal conditions, and only a very small amount gets transported into the urine. So with this very efficient process, out of the 0.2 to 0.6 grams per day that are actually made, between 12 and 36 grams per day are recycled in total. And that cycling happens between 4 and 12 times a day, depending on how often we're eating. So the disruption of this normal recycling of bile acids leads to decreased bile flow. And decreased bile flow is the definition of this word cholestasis. And cholestasis can be caused by multiple problems, either defects in the actual production of the bile acids, or in the case that we're discussing here, PFIC problems, abnormal transmembrane transport of bile acids. You can also have cholestasis because there's damage to the liver cells or damage to the bile ducts at a microscopic level, or if this large tube or common bile duct is blocked. And these are the mechanisms by which we can get cholestasis. PFIC in particular is caused by specific genetic defects in the transporter of bile components, various of them. And as they were identified, they ended up getting the numbers. So it's sequential relative to their discovery. Since the large bile ducts in these conditions are not blocked, PFIC are forms of intrahepatic, meaning within the liver, cholestasis, or within the liver lacking bile flow. And we have many now different forms of PFIC, all related to specific transporters, mostly along or around the bile canaliculus, that abnormalities in these transporters and the genes that give the instructions to make these transporters are altered or abnormal. And depending on the degree of abnormality in their function, might show up in many different forms or clinical manifestations of disease. So any chronic liver injury can lead to fibrosis or scarring. And so when it's very advanced fibrosis, this is called, or a special pattern of fibrosis in the liver, this is called cirrhosis. So the analogy I like to use is that if you were to continually scratch, as some of us do here, at our skin in one particular spot, it would eventually build up a callus from the chronic irritation. That callus in the liver is fibrous tissue, and when it's well formed, that callus becomes a scar, and that is cirrhosis, as is illustrated in these figures here by the blue staining areas of these liver biopsies. Bile acids, when they are accumulating within the liver from something that is causing cholestasis, and in particular with abnormalities in the transporters of bile acids, accumulate in the liver. And since they are basically detergents and the liver cells are made by walls of fat, lipid areas, they can get injured or dissolved. In addition, injury can happen because these chemicals signal the immune system to come and attack and repair the tissue that is getting irritated. And that leads to fibrosis, either around the bile duct itself or within the liver cells. So this chronic injury is what gives rise to the part of progressive in the name of PFIC. So how often does this happen? When we talk of incidence, that's the rate of an illness occurring over a period of time. And when doctors talk of prevalence, this means the amount of disease burden that might be present at one specific point in time. So with the number of live births occurring in the US, in the European Union, and the rest of the world, we've determined that the rate of all the various forms of PFIC is somewhere in the range of 1 in 75,000 live births. This ends up being roughly about 55 children per year in US and Europe, and about 112 in the world. And you see at any given point in time in the US or Europe, about 3,500 people are affected with some form of PFIC. As the vast majority of the PFIC diseases are called autosomal recessive diseases. That means that asymptomatic parents may carry one copy of an altered gene instruction. And so the risk of such a situation is that 1 in 4 children born to that couple is the odds of having an affected child. Now, those are all independent events, and in my own practice, I've had, although the odds are 25% for each pregnancy, I have had families have multiple children affected at the same time. So what are the consequences of the bile flow being decreased? Well, as an infant, it often can present as just irritability, which ultimately, once the child can identify the site of that irritability, ends up being demonstrated by itchiness. In addition, because of the role of bile flow in the absorption of fats and nutrients, there could be potentially fat malabsorption and diarrhea, and this can impair growth and lead to deficiencies in various fat-soluble vitamins, the main ones, the fat-soluble vitamins being A, D, E, and K, and this can impair the growth of the child. There also, if tested for, you'll find that there may be alterations because of the irritation in the liver, occasionally of the bilirubin, and only occasionally because it has a separate transporter than the bile acid, elevation of liver cell enzymes, and a special enzyme called the GGT, which lives on the bile ducts. And this value can be elevated or normal depending on which transporter is involved. But in almost all of these cases, there will be an elevated bile acid level in the blood. So the diagnosis is made nowadays by a combination of clinical profile and genetic testing. And as I mentioned, having an elevated serum bile acid is important in making that diagnosis. And we'll see non-specific changes in all these other enzymes. And we might find that there's an abnormal, if we tested for clotting, it might be abnormal, and it's due to having low vitamin K. Most of the ultrasound findings are related to making sure that there isn't another disease causing the cholestasis. And more frequently, genetics are being relied upon to try to distinguish the clinical features between making a diagnosis, because it becomes very hard to distinguish the clinical features between the various numbered PFICs. And there's different forms of genetic testing that are used, either targeted panels or more complete genome assessment. And we now know that there are many different ways by which the mutations can be seen in the various transporters that lead to the manifestations that we see as the clinical disease. Of the 6 main types that have been identified, with the first 3 being the most common, pretty much everything is presenting shortly in infancy, and gradually there is some progression of the scarring and dysfunction in the liver, and in some, like PFIC1, there can be other findings such as very profound diarrhea, hearing loss, or impacts on the pancreatic function. PFIC2 has primarily the dysfunction of excretion of bile and fat malabsorption. And then there's a more progressive injury to the bile ducts themselves with PFIC3. There can be progression of the liver disease because of this chronic irritation, and fibrosis does eventually develop toward adulthood. It represents combining all the forms of PFIC, 10 to 15% of transplants in children. And now recent data shows that about 50% of children with PFIC1 or 2 will be transplanted by the time they're 18. And you can have severe pruritus with this, which we'll talk about a little bit later. And this is just another one of my patients who had chronic pruritus with the scarring that might happen. And it's often the feet and the palms of the hands that are sites, but it can be all over. So what do we do about this? Well, in general, historically, the support has been, it's been supportive care aimed at trying to provide symptomatic relief of pruritus. When needed, transplantation, and some surgical options to decrease the accumulation of bile acids in the liver. How we did this support included nutrition, using specialized formulas that do not need bile acids to be absorbed when they were little, using extra medium chain fat formulas, and supplementing large amounts sometimes of fat-soluble vitamins. On frequent visits, we would monitor their weight and growth, monitor general labs, and intermittently obtain abdominal ultrasound, or when concerned, getting an MRI to look at if there was any kind of lesion developing. In the past, we would occasionally do liver biopsies to judge the exact extent of scarring that was happening in the liver. In the last several years, we've been utilizing non-invasive techniques, something called transient elastography, which measures the stiffness of the liver and correlates pretty well with the degree of fibrosis in patients. There were many, many different kinds of unproven, unstudied medical therapies to decrease the itching that happened with these in patients with PFIC. Ursodeoxycholic acid is something to promote bile flow, which sometimes was used. Rifampicin, which is an antibiotic, which happens to induce more of the expression of the transporters, would be used. Binding agents, and many others. And we've also utilized surgical techniques, which I'll talk about next. So because of this buildup of bile acids and because of the very tight reabsorption of bile acids at the last part of the small intestine, early researchers led by Peter Whittington in Chicago at that time implemented what was called a biliary diversion. In the first cases, it was called a partial external biliary diversion, which used a loop of small intestine connected to the gallbladder and brought out to the skin as an ostomy, draining into a bag to eliminate the continued absorption of bile acids in the body. This turned out to be fairly effective. Then other techniques to avoid ostomy were also utilized, where the small intestine was diverted before it got to the terminal ileum connected to the colon, or the gallbladder was connected directly to the colon. All of these cases, types of surgeries would work in some of the patients, but wouldn't necessarily work in all of them. It did ultimately, with the internal or ileal exclusions, it was found that reuptake kind of was readapted in this section, and so a lot of the prevention of the itching was lost over time. So the two companies, Albireo being one of them, supported a major study looking at the natural history of what happened to patients who had biliary diversions in the two largest groups of PFICs. And it was shown that those patients who had very good clearance of elimination of accumulated bile acids in the blood had excellent long-term survival with their native liver, meaning they did not need to go to transplant. Whereas those who continued to have very high levels had a very high level of needing the transplantation. So as a result of those kinds of observations, and because we knew there was a very tight regulation of reabsorption of bile acids, and that this may have a significant impact in the progression of the disease and correlated closely to the degree of itching that was happening in patients, drugs were developed that block the intestinal site of the reabsorption of bile acids, causing them to be excreted in the stool at a higher rate and gradually decreasing both the amount of bile acids in the blood and those accumulating again in the liver. And the one of these principal ones is odevixibat, which we'll hear a bit about a bit later. And it showed a significant decrease in the observed itching score in all patients on 2 different doses, and this was maintained over a long period of time. So we now have FDA-approved, non-invasive mechanisms, approaches to relieve pruritus in the treatment of patients with PFIC, and based at least on the observations we have from the long-term results of those who have successfully lowered serum bile acids from partial external biliary diversion, the hope is that this would delay the progression of liver disease and potentially delay the need for liver transplantation in some of these patients. Liver transplantation is indicated primarily in up to 50% of patients with PFIC who have not responded to any other means. As we'll get into a little bit later, it's a very debilitating symptom. It's not the first option because, of course, there can be complications of retransplantation rejection and unlikely but possible death. There can be complications specifically still seen post-transplant, depending on the underlying PFIC mutation. This is particularly true in PFIC1. We have demonstrated that post-transplant there's improved growth in the PFIC2 patients compared to PFIC1. So overall, I hope this has helped in some of the background of some of the things the doctors that you've seen have told you before, and it puts it into a little bit better context for you. I am optimistic for the future. I think it's much brighter than it had been in the past. I think we do have more options now for therapy that target specifically the mechanism of disease development by the intestinal bile acid transport inhibitors. And this could potentially be a very big game changer for some. But we still have many questions and have to continue to do our research both clinically and at the basic science level, and to learn whether the early introduction of intestinal bile acid transporters, does that alter the natural history of patients when they are treated from a very young age? Are there specific forms of PFIC that respond better to IBAT inhibitors? Does non-response at an early age to IBAT inhibitors suggest that maybe biliary diversion shouldn't be tried? We don't really know that answer yet. And whether the combination, whether IBAT inhibitors alone or in combination with other medications, which one of these techniques will be better suited and in which patients, we have yet to discover. So I thank you very much for your attention. Hopefully that wasn't too long, but hopefully it gives you a background on the issues that will be brought up by your physicians in caring for your children and yourselves in the future. Thank you very much.
Thank you, Dr. Romero. That was fantastic. It really, at least for myself, opened up a lot of questions that I had, very detailed. Thank you so much. Yeah, I appreciate it. Thank you. In tonight's program, we are offering a special edition of a patient's journey. The patient and her parents are here, so I'm going to ask Dr. Romero to say a few words regarding and introducing their family so we can listen to their story of living with PFIC.
Thank you very much, Ms. Douglas. It's my pleasure to introduce Mr. and Mrs. Will, Ryan Will, and Laura Will, and their daughter, I think, is hanging out there also, Charlotte. I've known this family now, we were just reminiscing, almost exactly 10 years where we began that journey. And there they are, Ms. Will, hello there. Mr. Will, hey. And Miss Charlotte, how are you? Okay. Doing her best, drinking her water. Thank you very much. So, yeah, it was I am quite certain that when we first met, it was a very hectic time for the Wills. After a little bit of a circuitous journey to land in my office on the 6th floor of our hospital where we had our clinic, and meet this guy they never heard from Adam before, and start trying to figure out what was going on. And so I'm not sure who to open it up first. My guess is Ryan's going to talk first, but you know, I think one thing that was always interesting to many folks, I think, is, well, how did this all begin, and when did you think something was different? So I'll start with that question.
So I appreciate it. I'll try to be brief. We would be together, but for the West Coast people, I'm actually in beautiful Ojai, California, for some business meetings this week. So I'm actually able to be a good time because it's about Charlotte's bedtime. So
yes.
First, thank you very much, Miss Douglas. I know Miss Clemson will be speaking here, I think, shortly, and obviously Dr. Romero. I mean, just for everybody, I mean, it's almost impossible to thank you enough. I mean, I couldn't even start. I could be on this thing for an hour talking about you.
Well, please don't. Let's talk about it.
You're truly a superhero. And I've already cried like twice, you know, like just thinking back as we've been on. So to answer your question, you know, we started chasing the rabbit with Charlotte when she was 6 months old. You just mentioned when children, I think, have the ability or the propensity to start their itching where it itches. And I can remember Laura took a video. We took a video of Charlotte after she came out of the bath, and we still have these videos. We occasionally will revisit them. I don't know why we do that to ourselves, but we've even shared them with Charlotte because thank God she doesn't remember. But you know, she would just be going at her body everywhere. I mean, it would just be so incredibly tough to watch. And you know, you talk about a newborn sleeping through the night, and she just there was nothing normal. I think you go with your parental gut, and we knew something was wrong. And honestly, thank God we live in Atlanta, or greater Atlanta. We're north of the city, but you've just got so many great doctors. And you know, we engaged with our pediatricians, and they got you know, the whole team, and we went to all sorts of different specialists. You know, did she potentially have cancer, or did she have this? I mean, nobody could really figure things out with blood work or whatever. I wish I could remember the doctor's name. It was there off of 285 near Northside Hospital, the baby factory, as everybody calls it in Atlanta. And we met with that guy on like a Thursday, and he was a really well known allergist, I believe. And it was a Thursday, and he knew that we were meeting with you on Tuesday, and I think he knew you, and that guy was onto it. He said, I think you're going to get the answers you want on Tuesday. I'm pretty sure it was a Tuesday when we met with you. And, you know, that was 2 months later. Charlotte was, as we were just talking about before this started, she was 8 months old. And you came into the room. I mean, there's a ton of, it's a movie, right? And there's so much that you could tell, but I remember you came into the room with the old textbook, as I recall. I mean, it was like this thick, and it looked like it was from 1965, some sort of, you know, medical book. You know, it was like 50 years old, and you know, the cover needed to be dusted off, and you opened it up, and you started talking. And I just remember, to me at least, the crackling in your voice, and I felt like you were a little bit nervous to tell us what we were about to hear, which was just like getting hit over the head with a 2x4, right? That your daughter's got this amazingly rare disease, and you know, it's something we're gonna have to deal with, and it's not going to be a sprint, it's going to be a marathon. And now here we are 10 years later, and yeah, so
gone through a lot. Laura, let me ask Laura a question here. So when you when you were first kind of dealing with it, did you end up going through different formula changes and like, and what kind of, that's often something that we've seen, like it's attributed, oh, it's reflux, oh, it's this or that. What do you recall of that? You got to unmute yourself.
You got to unmute.
It'll
Okay.
happen. There you
Can
go.
you hear me?
Yes, now we can. Got it.
Okay, good. I actually take medication for seizure control. So that was one of my biggest fears. We were just so uncertain on what it was. So we were, like Ryan says, sort of just going down a list of could it be, could it be?
Mhm.
And I actually stopped nursing her in July and would have kept going just for fear that that may have been what the problem was. So then we started switching to formula. And I think by the time we got to you, we hadn't switched a whole lot. I don't really remember, but I do. The whole breastfeeding and is it my fault? Is it the medicine I'm on that's triggering her to do this? That was a pretty certain concern of mine. I felt pretty confident that that could possibly be what it was. But obviously ended up not being,
Sure.
the
Well,
fix.
I've never met a mom who didn't think that she had something to do with something happening to their child. So
Yeah.
that's so very, very common. And I think one of the things that is very, so it is very common for a child to what we would call have a delayed diagnosis. But the fact of the matter is it's hard. It's a hard diagnosis to make because you're not getting any specific symptoms, and irritability in a young baby is can be 1,000 different things, from from a hair wrapped around a toe to reflux irritation to allergy to eczema to all these things that are focused and much more common of itching or other manifestations of irritability are much more common and always going to be the first 5 things that are going to be looked at, until at some point labs get drawn for as kind of like one of the last, because no one's drawing blood on an infant who isn't overtly jaundiced, because this is another thing that's different about PFIC2 is many times that although the bile flow is disrupted, the excretion of bilirubin is not quite as affected. And so you may not have very high levels of bilirubin, like full-blown obstructions. And so there isn't the immediate clue, aha, my liver's off because I'm yellow, right? And so that becomes a hidden kind of sign, right? And so it is not until after reflux gets ruled out, antacids are tried, formulas are changed, an allergist gets seen because finally they started itching, and a dermatologist gets seen because they think it's eczema and it's the worst eczema we've ever seen, although there's no rash. That finally the LFTs get checked, and maybe the bilirubin is a little bit above normal, and maybe the AST is in the 50s or something like that, and that prompts the referral to a gastroenterologist or a pediatric hepatologist. So that's overwhelmingly common. And then you're faced with the kind of the workup. Do you remember any parts of the workup at all?
Well, her platelets were always crazy elevated. And that was kind of, I don't know if that was a little bit different than other.
So that's actually now a well-recognized kind of part of this, possibly driven by the inflammatory signals of increased bile acids. So that's now a well-described kind of feature, although not necessarily the one that everybody focuses on to make a diagnosis, but it's an associated finding. But yes, I remember very well, we didn't, at that time, have a clear understanding what's driving that.
And Ryan, do you remember anything specific from that first lab draw or two?
Well, no, the platelets were definitely elevated, and that's why a lot of people thought potentially. In fact, I can't remember, Laura, if we went to Scottish Rite, Children's Hospital, Scottish Rite,
For hematology.
but yeah, a lot of people thought possibly it was, some sort of cancer. And I mean, as crazy as this is to say, I think we even thought when we started realizing what we were headed down the path of at that point, when we knew she was finally diagnosed, like, geez, maybe it would have been easier if she had cancer, right? And that's probably
Yeah.
one of the most, it's probably one of the most frustrating things about this disease, right? Is all the money goes towards cancer, or it just doesn't seem like there's a lot of attention put on things like pediatric liver disease. And
But, yeah, no, you're right, Ryan. This is an orphan kind of disease, as they say. And so, and because there's fewer people impacted, obviously that has an influence on this. I'm sorry, I interrupted you.
no, I mean, I just think, yeah, I mean, and that's why stuff like this is amazing. I think just to get, I guess, obviously, if it can help other families, but also just to continue to draw attention to, it is truly to see your child just basically mutilate themselves. And that's what it is. I mean, it is truly the scars and the scratches and the bleeding and we kept the Band-Aid companies in business. I'm sure we're not the only families that do. The sleepless nights. I mean, Laura, thank God. I mean, honestly, for her, I mean, she was working through several years of the early years of Charlotte, Charlotte's years. And then, she's fortunately not, worked for the last 5 years or so, but I mean, it was always, it's your turn. It's your turn. I mean, it was never, I don't think we ever had a string of 3 to 5 sleepless, sleep all the way through the nights. Maybe, I don't know, Laura maybe would remember, and I don't want to get ahead of this, Dr. Romero, but maybe after her biliary diversion surgery, I mean, we went the full gamut, right? So you put up the management, we did all 3. We started with the meds, then we did she was 20 months old. We did the biliary diversion surgery. It was a really hard decision to make. I mean, my God, I can remember how fearful we just were just to put her under to have a surgery, let alone have an ostomy bag.
Well,
right.
Before that, we had to discuss about, we did our biochemistry labs. You got used to getting poked at an early age, right, Charlotte?
Yeah.
Getting our lab works done, it's like, I don't know how she didn't hate coming to see me, because we knew there was going to be blood work every time I saw her. And so, yeah, that initial phase was looking for alternative liver diseases that might present the same way. And then the characteristic finding, at least in PFIC2, which is what Charlotte has, of elevated bile acids, but a normal GGT. And that really kind of clued us in. And around the time that she was born, it was getting more readily available, the genetic testing. And so we were able to confirm the presence of mutations in the ABC B11 gene, which is the one that it gives the instructions to making the transporter of the bile acids. That was found to be abnormal. And so that confirmed. And yeah, I remember talking to you a lot about the liver biopsy, how we were going to do it, how it would be important, necessary to know in order to decide whether it was appropriate to do a biliary diversion. Had the biopsy showed a lot of fibrosis already at that time, then that would not have been a great choice. So that was kind of a deciding point. But I clearly remember very well the discussions we had about the ostomy. As bad as the sleep disturbance was, and how much stress I can only imagine that placed on each of you, the thought of an ostomy bag really was hurtful, to be honest, to you. I know that. But I also pushed that one because I thought it was, in my opinion, at least in our center, was the most assured way to get rid of most of the bile acids the best without a reabsorption issue happening. And so I think everything bought us a little bit of time, and it bought us some time to let Charlotte tell us some more about what was happening, right? So Charlotte, can I ask you a little personal question? When did you really, do you remember like the first time you realized, oh, I have an ostomy? Not that you called it that. What did you call it?
Your stoma you named.
A stoma, yeah.
Stoma.
I called it Rosie.
Rosie? So when did it start to bother you? What do you think?
I think mostly in like 3rd grade and 4th. Like that's because I didn't really realize it in 1st and 2nd because I didn't really bother with it. But like in 4th and 3rd grade, and I really just I couldn't do my work. Like I couldn't focus. Like it was a big deal. And I wanted to wear like bathing suits to show my stomach, and I couldn't do that. Because I was like, what if people ask me questions? Like I don't want to answer that. Like I don't want people staring at me and be like, what's that?
Sure. No, I think that was that's very helpful. You know, and I think we discussed that, you know, early on it wouldn't make a difference, and we knew that as she grew older, it might, right? And we talked about potential options later of, this is before Odevixibat came out, about reversing it, doing an internal diversion. We talked about that, you know, and obviously throughout all this, we were talking, when is it time to do a transplant? And what was clear is she wasn't having progression of fibrosis, but the itching would have periods of up and down, right? I mean, it was never gone even after the medicines plus the diversion, but there were periods where it was a little bit more tolerable and a little less tolerable, right? Yeah, a real waxing and waning.
Yeah,
yeah. You know, and I can't tell you what provoked that, but that was pretty definitely what was happening. And what I'm going to ask Laura, Ryan, okay. What do you recall? So when did we come, is your recollection of when we came to the decision that, well, before that, we had the opportunity to enroll in the research study. And how did that go with the intestinal bile acid transport inhibitor? How did that go?
Well, we had actually listed her, and transplant was not our first choice. Obviously, we tried that. We weren't a family that wanted to jump immediately into transplant. You know, we wanted to try all the meds we could, do the ostomy bag, and you know, if she could have lived a comfortable life, as difficult as it would have been, we would have kept the bag, but that wasn't doing its job anymore. But we listed her and we ended up removing her. So we started the trial drug after that, and it worked for us. That's what you asked me about, right? The trial.
Yeah. So I did, what I recall was that, yeah, we ended
It was up and
putting her
down.
on the trial. Yeah, we put her on the trial, and it worked so well that we were able to kind of back off and actually put her inactive on the transplant list.
That's correct.
And watched her for a good long period of time. And then unfortunately, we got COVID, and that changed everything for whatever reason. That's not like something that's universally known or anything like that. But it was just something that really, even though she was not sick, it changed probably something about the inflammatory cascade that it provoked, did something different to the bile acid transporters, and we were not getting the same.
It never worked again. After we were in that hospital stay for about a week, a month or so after COVID, it never did the trick for us anymore. And we kept trying for a while, and it never turned itself around.
So we ended up listing, and because of the nature of her disease, you don't get a very high score for your listing priority, but there is a known ability to get extra listing points for when you have terrible pruritus and you failed everything that's available. And we were able to get some points, and we talked about living donor, and in the Southeast, we have a favorable organ donation rate, and we were able to move forward with that. But Ryan, what do you think? What do you recall about waiting on the list and the phone call?
Yeah. You know, it was I think we finally did get to the point where just to make that decision first and foremost, right? Like you were talking about, and Laura was talking about, and Charlotte was talking about, and I'm sure every kid is different, right? Charlotte to me is a rock star as well, right? I always say she's the toughest kid I know. Hey, I went and got my first tattoo at 46 years old for this little girl, right? We had a deal. She got a transplant, daddy got a tattoo. So, but you know, we listed her, and like Laura said, we listed her that first time, and then we didn't do it, and that was scary. I think we just, you know, for me, honestly, there was a lot of faith involved in that decision. I mean, I think we had to believe that, you know, you were our quarterback, you've been our quarterback through this whole process, but at some point you just got to put things in a bigger hand, right? It wasn't in our hands anymore. She was living a miserable life, and she was getting older. Laura would have to have, you know, teachers send stuff about, you know, from school, right? Like how, well, you could tell she was really itchy today. And, you know, and she was such a trooper. She probably, I mean, she remembers this to an extent, I think, but you know, she would get up in the front of her class every year and show them her ostomy bag. Now imagine a little kid having to get up and say, this is my bag and this is what it does. And, you know, it helps my liver disease. And some kids are super inquisitive, right? They ask like really deep questions, like their future Dr. Romero's, I guess. And then some are like ask goofy questions, right? But she did those things. But we listed her, and you're right. We were able, gosh, I forget. I was going on a trip or something, and I go to Montana every year. I do a volunteer week at a ranch for like a men's retreat, and literally 2 days before we go, I think you or somebody from the office had called, and I mean, her score shot up. And then with the whole UNOS thing or whatever, you can kind of pull up and know her blood type, and we could kind of figure out, I'm like, oh my God, she's like, and I still don't know. I know it's like the 500-mile radius, and you know, you got all these different things.
All these rules, yes.
And it's all, yeah, it's crazy. But we had, thankfully, another patient that you know of with Dr. Carpin, their family, I mean, and how crazy is this? Their daughter had developed a liver disease sort of, or, you know, an issue later, and had gone and had used to reach out to Laura for support. And now she had transplanted, they had been through it all. And now here roles are reversed, and Laura's reaching out to her for support and stuff. But we kind of figured it out. And I was actually traveling out here, and I was actually in California. It was a week before the Super Bowl.
Charlotte, tell what happened real quick.
And then it was a Friday evening. What happened? What happened, Charlotte?
Tell the story.
Okay.
Go
ahead, Charlotte, tell us.
So what were we doing? Where were we? What happened?
Oh, where were we?
And the call coming in and what happened.
Oh,
Look at
I was in bed eating candy with my parents because it was a weekend.
Not encouraged by anyone, right?
And my dad was brushing his teeth. He's like, okay, Charlotte, you need to get ready for bed. So I say, okay. And he's brushing his teeth, and he gets this phone call, and he makes a joke, and he says it looks like somebody's number or something. And then he laughed, and then, well, it was my mom's phone. And then my dad gets a call because my mom missed it.
I missed the call, and then Daddy's phone rang.
And then so we looked at it, and it's the same number. And my dad's like, what number is it? And he's like, my mom's like, oh, it's the same number. And she's like, wait a second. And then my dad's like, answer the phone. and then we end up missing it. And my mom's like, oh my gosh. And we end up calling it back. I get out of bed. I just throw the candy. I'm like running to my brother's room. I'm like, OMG Hudson, I might get my liver transplant call. And he's like, and he's playing his video games with his friends.
All right.
And then
We
got
packed
the,
our bag and
we
we went.
We did everything they tell you not to do. We hauled ass to Choa and went like 80 miles an hour on it.
Words,
Friday
Ryan.
night.
Yeah,
words.
don't, yeah.
No, we got down there and we checked in at, you know, roughly midnight. We threw some things in, and then a bag. We had our clothes. You know, you get your bag ready. Kind of,
Right.
Laura and I kept stuff ready in the you know, in the closet. And no, we got the call. It was around 10:30 the Friday evening before Super Bowl Sunday this past February, and we went down, and obviously there was like a little bit of delay in the whole, you know,
Yeah.
you kind of go to
Hurry up and wait.
that's right. Nothing, everything that they tell you, I would say, is true, right? It's you know, you get there, and we waited, and then I actually went home back home Saturday evening because we knew, like, we were safe, like nothing was going to happen until sometime Sunday, and that enabled me to get home. And my mother you know, had come, and we still had our second oldest was still at home. She's a freshman in college now. So, you know, and I was able to kind of get what Laura and I really needed, you know, and got the house kind of organized and everything. And it the whole take a village, it does. And I drove back down early Sunday morning, and I think finally around 4:15 on Sunday, they brought her back, and literally, it'll just be easy to remember, right? She literally transplanted through the whole Super Bowl. I tell everybody, I mean, Laura and I sat in the waiting room there at Choa, and we were basically the only two people in there. And of course, I got the Super Bowl up on the screen, and I don't remember a play, right? I mean, it's just a surreal experience, and you're just praying and waiting for the updates that they call, you know, they give you the updates every hour and a half, you know, what's going on. And the actual transplant took about, I don't know, Laura, what, 6.5, 7 hours probably, was
Like that.
maybe a little bit longer from start to finish, like actually taking her back. I think we
Right.
finally saw her in the PICU probably around midnight, you know, and then obviously there was a little complication, not really to the transplant itself was perfect, but then that brought up an issue that we didn't even know she had too, right? So then we had to go back in on Tuesday and unfortunately kind of having to, you know, back into the OR, and that was tough. That was very tough.
Yeah, the
Toughest
first,
day, that was probably the toughest day of my life.
sure. These
How
are,
old was Charlotte at the time?
10. She was 10. It was just
Yeah,
past February.
yeah, it's
Yeah.
been 8 months or so. Yeah.
Yep.
So, and I think one thing to mention is that Charlotte was old enough already, and you know, you as a family had been experienced enough and gone through all the steps, right? That Charlotte was able to tell us, hey, it's time for me, when we were deciding to list, I want to have a liver transplant after we've had that conversation. Isn't that true, Charlotte?
Yes.
And I didn't push you to say that, did I?
Mm-mm.
No, I didn't think so. So, I mean, and it was clear she had deep scratches all over her body. I think, I don't know how well Ryan and Laura's mental status would have been with any more additional sleepless nights going on. And that is a huge driver of quality of life issues. And that's come out in all the studies for the intestinal inhibitors, a huge issue driving, and a huge stress within families, within marriages, within between siblings. I mean, it isn't one person who has PFIC, it's everybody.
Yeah, and the thing you don't think about, I mean, I'll be quick, but vacations, we would either not go, or Charlotte and I would stay back because she couldn't go to the beach. She was so miserable. School, she checked in late because she didn't sleep all night. So it's not just the itching, like you said, it sort of encompasses their entire life. You know, it literally changes your family dynamic. It's tough.
Well, and
So-
it definitely impacts the other. I mean, we have so Laura had, I have two older daughters from Laura's previous marriage. They were 6 and 3 when Laura and I got married, but they're in college now. We have a senior in Athens and a freshman in Athens, and a son who's 13. And you probably don't, we probably still don't really know how it impacted each of them individually. I mean, we do, but we don't, right? I mean, it takes a lot, right? It's a lot. It is a ton of stress on your marriage. It's a ton of stress, because everything gets, everything with Charlotte was a priority, right? And different times. And, to your point, when we finally did make that last decision to list her, you talked about it during your presentation, right? She had COVID, right? And although she wasn't sick, I mean, maybe for 24 hours had a fever, she ended up, whatever happened inside of her body, and her blood wasn't clotting, right? We end up at Children's Hospital, and she was very, very sick. And I think that was when we finally said, you know what, we're not going to mess with this anymore, right? We've got all these things. She's still itching. And I will say, thank God, 2 days after her transplant, she didn't itch, and it hasn't, knock on wood, and please never again. And her quality of life is, she's gained 20 pounds. So have I, since her surgery. She needed it. I didn't. And she's just, thankfully such a healthy, normal kid. And for families that maybe are on, or parents that are on and will maybe watch this, I mean, thankfully she doesn't remember itching. She doesn't remember, and it blows our minds that she doesn't remember how bad it was. But I think she's just luckily young enough that she doesn't really remember that much about how bad it was.
I don't think she's different in her life. She knew it's not like she didn't itch and started itching. She never knew it different. That was her life.
Ms. Douglas, she wanted to jump in.
Yes,
we may have expended our time limit.
I know.
I had no idea.
And we still have to give some time to Dr. Clemson, please. But this is no problem. No, this is a fantastic story, and I would like to set up some other time in future to have all of you again and talk about Charlotte's progress. It's very important for all of our liver patients, not just PFIC, but all the other patients, especially the ones that possibly have had a transplant, because we do have a lot of transplant patients that work with us. So this was fascinating, but with your permission, I'm going to jump into saying that, as I mentioned before, tonight's program has been made possible by an educational grant from Albireo Pharma. Now I would like to introduce Dr. Christine Clemson, Senior Vice President, Global Head of Medical Affairs at Albireo Pharma. Dr. Clemson is leading Albireo's global medical affairs function, which is responsible for ensuring that Albireo is established as a leader in the field of cholestatic liver disease. Some of the key responsibilities for medical affairs include establishing relationship with clinicians and care for patients with ALGS, PFIC, and BA. By the way, we have a BA webinar in December. We are trying to do, as you mentioned, Ryan, that these rare diseases are like orphan children. So we are trying to bring that to the attention of everybody. Now, going back to Dr. Clemson, she is also responsible for field medical support of the commercial and market access team, publication, external and internal education, as well as scientific grants funding. Christine spent 20 years in academia studying non-coding RNA at the University of Massachusetts Medical School, where she earned both a PhD in biomedical sciences and a master's in clinical investigations. She then transitioned to pharma in the rare disease space, working and gaining experience in several global pharmaceuticals. Her most recent tenure before Albireo was in women's health, working at Sage Therapeutic, leading the medical team during the launch of the first approved drug for postpartum depression. And at AMAG, where she led the medical support for the women's health franchise. Dr. Clemson, would you please say something about your work? at Alberio, and we thank you again for your support and your educational grant.
Thank you so much, Farah. Thanks for having me. Thank you so much, Dr. Romero, for the excellent presentation. I actually learned a lot. And thank you so much, Laura, Ryan, and Charlotte for the excellent presentation and sharing your experience with us. I will share my screen. Great. So I work at Alberio Pharma, and today I'm going to give you just a very brief presentation on Bylvay to treat itch in PFIC. The program, as Farah has talked about, is sponsored by Alberio, and we make Bylvay. What I will talk to you today is just an overview of Bylvay, which is intended for U.S. patients, caregivers, and caregivers of U.S. patients with PFIC. The information provided for you is for educational purposes only, and it's not intended to suggest or provide treatment, diagnosis, or medical advice. And of course, for any questions about Bylvay and whether it's right for you or your child, please speak to your physician. So Bylvay, also called Odevixibat, is the first and only FDA-approved medicine for itch in patients with PFIC. What is Bylvay? It's an oral ileal bile acid transport inhibitor that's approved by the FDA for treatments of itch or pruritus in patients aged 3 months or older with PFIC. You take this medicine once a day in the morning with a meal by mouth. Bylvay is approved for all forms of PFIC. However, it may not be effective in one subtype of PFIC2, in which the BSEP transporter is completely removed or truncated. Bylvay comes in capsules, and the capsules can be swallowed whole, or you can open up the capsules and sprinkle it on a little bit of food. Bylvay is extremely well studied. It's been studied in the largest clinical trial program in patients with PFIC. So what we found in the clinical studies, there was one large initial study, and we have still an ongoing study to look at the long-term effects of Bylvay. But what we've reported so far is that patients with PFIC age 6 months or older were studied in this program. Almost all the patients included in the program had significant itch at the start of the trial. There were 2 doses of Bylvay studied, along with a control or placebo group. And the patients took the medication daily with a meal for 6 months. The study looked at a variety of outcomes. The primary outcome was a change in the itch score that the parents or the patient filled out every morning and evening. And the study also looked at the side effects of the treatment. And as I said, there's still one study ongoing that is a long-term study. The way this itching or scratching was measured was through a scale. And you can see here on the left a visual picture of what the child is asked about in terms of their worst itching. The patient or the caregiver filled the scratch score out in the morning and the evening. And this is how we were able to monitor the change in the scratch scores over time. And so what we saw, you saw Dr. Romero presented some of the data, but what we saw is that many patients had improvement in scratching as early as 4 weeks. Many patients eventually had little or no scratching, and most patients had improvement in their worst itching throughout the study. So the safety highlights are that in the clinical study, 83% of the patients treated with Bylvay and 85% of patients who took the placebo had side effects. Most common side effects during the study were diarrhea, liver test changes, vomiting, stomach pain, and problems with absorbing fat-soluble vitamins like A, D, E, and K. The important safety information is reiterated here, that if you take Bylvay or your child takes Bylvay and they experience any of the side effects like abdominal pain, vomiting, diarrhea, and dehydration, you should speak to your doctor. And there are recommendations for following your liver enzymes and your fat-soluble vitamins, which folks with PFIC should be monitored for anyway. So in summary, PFIC is a rare liver disease that often causes itchy skin. Bylvay is the first and only medicine approved for itch in patients with PFIC. In the clinical studies, we showed patients with PFIC treated with Bylvay showed a decrease in their itching, and we discussed the common side effects. If you have any questions about whether Bylvay is right for you or your child, please speak with your physician. So the next thing I'm going to talk about is the program that Albireo has to help patients and caregivers who have been prescribed Bylvay. So Albireo Assist is the program we have, and it's run by Albireo employees, and it's really there to support the patient and the entire family as they navigate through their PFIC diagnosis and their treatment. So there's dedicated live support, there's financial and insurance assistance, there's care logistics, as well as educational materials and programs. The services offered by Albireo Assist are financial and insurance assistance, as I've said, live support and dedicated live support, so you can always talk to somebody if you have questions about the disease or your medication. Albireo Assist also can connect you with the right specialty pharmacy based on your insurance to get your prescription filled and get your refills. And then, of course, patients and caregivers often have questions about the disease and our drug, and Albireo Assist can offer educational materials and programs. And with that, I'd like to thank you so much for your time and attention. And if there are any questions, please put them in the chat.
Thank you, Dr. Clemson. Thank you very much.
Thank you.
Sure. I want to thank again Dr. Romero. I know it's very late in Georgia, and I want to thank the Bell family, Laura, Ryan, and Charlotte. Beautiful presentation. I wish we had more time that we could hear more of your story, but unfortunately we ran out of time. Hopefully we'll get you back soon. And I also want to thank Albireo Pharma for their grant and support. Now I want to give you a couple of little advertising. This Sunday, September 18th, we have a walk in Santa Monica. The walk chairs are Dr. Fadi Caldas from UCLA and Ms. Molly Clark, who is a young biliary atresia patient. We will have, it's a family-oriented event. We will have face painting, balloons, refreshment, music, and it will be a fun day. And on the September 30th, we do our annual Salute to Excellence dinner gala. During this program, we will honor some of the best hepatologists and liver surgeons. Some of our honorees are Dr. Coley from CHLA, Dr. Imagawa from UCI, Dr. Nissen from Cedars-Sinai, Dr. Kim from Cedars-Sinai, Tom Mon from One Legacy, and Nurse Andrew Bird from UCLA. We hope you join us. Our second walk of the year will be in Orange County on 16th of October in Irvine. The chair of that walk is a 15-year-old autoimmune hepatitis patient. That walk will be very similar to the walk in LA with all the music and balloons and everything else. Our next webinar is on October 12th on liver cancer. Two of the best hepatologists and cancer specialists in Greater LA will be speaking about liver cancer and all the new treatments that may be available. To register and participate in any and all of our events, please visit our website, liverhealthfoundations.org. Thank you again. Please visit our social media site and like us. I really appreciate all of you who stayed with us during this long project tonight we had, but I'm sure that we all learned a lot. I definitely learned a lot, and especially was fascinated by the Will family story. We hope to see you all at the walk in LA on September 18. Good night and be well.
Good night. Thank you.
Thank you.